there, this is Lindsay Lopez from Southeastern Physical Therapy. I'm joined today by Dr. Rob Mason from Tidewater Orthopaedics. Dr. Mason, thanks so much for joining me today. How are you?
Not too bad. How are you doing? Thanks for having me.
Absolutely, I'm doing well. So Dr. Mason, I'd like to talk with you a little bit about elbows. What are some common elbow injuries that you see?
So probably the most common elbow injuries / conditions that we typically see are really, the most common is your epicondylitis, your tennis elbow, your golfer's elbow, kind of lump those into one and the same. Another common thing that often kind of comes up is more of a nerve-related issue, but can be kind of cubital tunnel syndrome that people get on the inside of their elbow. From an injury standpoint, probably the two most common things, like a true injury, are radial head fractures from a blow right to their elbow, and also probably your distal biceps tendon ruptures.
Okay. So how do you typically diagnose and then treat some of these injuries that you've mentioned to the elbow?
So your epicondylitis or your golfer and tennis elbows is really mostly a clinical exam. I get an X-ray initially just to kind of rule out, other pathologies. But that one's pretty much a clinical exam. You sore over the elbow, and if they either have pain with resisted wrist extension or resisted wrist flexion are kind of the common, depending upon whether it's golf or tennis elbow. For cubital tunnel, that's usually the patient with numbness and tingling in their hand, but also pain shooting from their elbow down to their ring and small finger. Initially, when you're concerned about that, usually I'll get a nerve study to rule out, impingement of the nerve around the elbow. And then for your radial head fractures and your biceps tendon ruptures, distal biceps tendon, radial heads is an X-ray. You have a patient with a traumatic event, they come in, you get an X-ray, usually it's identifiable on X-ray. And then for your distal biceps, that's often a clinical evaluation as well. Usually we're getting an MRI or possible an ultrasound for confirmation of our pretty high suspicion that it's a rupture. And usually then you're kind of looking maybe just to see how far it's retracted and stuff like that, more for surgical planning.
Okay. So you've talked a little bit about some of the common things that you see. Are there any uncommon elbow issues or injuries that you've diagnosed and treated?
Probably more uncommon is maybe more uncommon conditions is, especially nowadays with the rheumatological medications. Rheumatoid arthritis is much less prevalent in terms of how bad it affects the joints compared to what it is in the past. And so one of the things we do for a really bad rheumatoid elbow is elbow replacements, and you hear that, and a lot of times people, really, you can do an elbow replacement? And it's not done very common, and there's certain lifelong restrictions with elbow replacements that there are reasons you don't do it in everybody. But for an elderly patient with bad rheumatoid arthritis, usually, an elbow replacement is actually a pretty good solution for them, but usually always a last resort as you have a lifelong restriction of about 5 to 10 pounds on that arm.
Oh, wow. Okay.
There's some other kind of rare fractures, terrible triad injuries where you'll have a radial head fracture and a coronoid fracture and an elbow dislocation. Those get to be a little bit tricky just because of the therapy afterwards. Complex elbow fracture dislocations really require a lot of therapy afterwards to try to get your best outcome. They don't call it a triad injury for just because it leads to a lot of stiffness, and it's really a big component of a 3-team approach between the therapist, the surgeon, and the patient.
Okay. So if someone comes into your office and they're experiencing elbow pain, or they've had some sort of injury, what does the process typically look like? As far as exam, imaging, physical therapy, surgery, kind of what are the progressions?
So obviously a lot of it depends upon where you go along those steps, but usually the first and foremost thing for me with an elbow, pretty much mostly everybody gets an X-ray to rule out things like arthritis, rule out fractures if they have an injury. If it's something that's more of a clinical diagnosis, like a tennis elbow, usually after the x-ray, if the clinical exam shows me that, then, a lot of times it's just, treatment with therapy, injections, other symptomatic management with the braces, stuff like that. If it's more along the lines of a fracture or a soft tissue injury, like a distal biceps, sometimes you're getting an ultrasound or an MRI if you're for surgical planning. For radial head fracture, a lot of it depends upon what the x-ray shows. A lot of those don't always need a surgery. It just depends on how displaced the injury is and whether or not you need, maybe some additional imaging like a CT scan if you're concerned that it's on the fence of surgery versus not surgery. And then for radial head fractures, a lot of times, therapy is important afterwards to try to get the motion back, because the one big thing with elbows is stiffness. And, that's why it's very much a three-team approach to try to get the best outcome after any elbow injury, because you got to try to overcome that stiffness, afterwards. And that's where the therapist really comes into play.
Okay. So do you have any tips or suggestions as to how someone could avoid, potential elbow issue or injury?
Certainly, with some of the conditions that I talked about, I think getting an early evaluation and on the proper treatment regimen to try to help get it before it gets worse, to improve it before it gets worse, is important. So your lateral epicondylitis, your medial epicondylitis, those type of things really are not things you want to kind of, sit around forever, because, there are things to try to keep it at bay. They'd stick around for a long time, but if we can keep it at bay and under a more comfortable position for the patient, then it doesn't get aggravated as bad. Other things, for distal biceps ruptures, the big thing with those, for people to try to, when they're doing training and lifting and things like that, eccentric activities where they're kind of doing heavy weights and just kind of trying to hold that position and work on an eccentric motion, is when those happen. So if you're starting to have kind of anterior elbow pain, it's better to get looked at, because oftentimes there'll be some telltale signs before it ruptures that you're having trouble. And if you continue to work through that, sometimes that leads to a rupture, where if it was a partial injury, you could potentially at least scale back some so that it doesn't actually rupture.
Okay. So Dr. Mason, where do you typically see patients?
So I see patients at our Hampton office and our Suffolk office. Our Hampton office is 901 Enterprise Parkway in Hampton. And the Suffolk office, we're at the Centera Bell Harbor building, which is 3920A Bridge Road, suite 305 up on the 3rd floor.
Okay. And if a patient would like to set up an appointment with you or your office, how should they go about doing that?
So the most efficient way to do it is actually on the website, tidewaterortho.com. You can make your appointment. You can pick a day, any of the days of the week that I have openings. Obviously, they can also call the office to 757-837-2480 and speak to someone to set up an appointment.
Okay, wonderful. Well, thank you so much for your time today. I really appreciate it.
No problem. Thanks for having me.